Smoking-induced vasculitis of the central nervous system, CNS, is a rare condition where inflammation of blood vessels within the CNS occurs, potentially leading to a variety of neurological symptoms. The inflammatory process can result in damage to the blood vessels, leading to reduced blood flow, ischemia, and in severe cases, stroke-like events. Here's a closer look at the mechanisms, potential presentations, and diagnostic considerations. Mechanisms and pathophysiology. One, vascular endothelial damage. Smoking introduces numerous toxins that cause oxidative stress, leading to damage of the endothelial lining of blood vessels. This damage can trigger an inflammatory response, promoting vasculitis. Two, immune system activation. Smoking can dysregulate immune responses, leading to an abnormal immune-mediated attack on the blood vessels. This could contribute to the development of vasculitis, including rare cases of CNS involvement. 3. Hypercoagulability. Smoking increases the risk of thrombosis and clot formation, which can exacerbate vascular inflammation and contribute to complications like thrombotic vasculopathy or stroke. Clinical presentation. The symptoms of CNS vasculitis related to smoking can be varied and may include headache, a common presentation due to the inflammation of cerebral vessels, neurological deficits. These may vary depending on the area of the brain involved, including focal neurological signs like weakness, numbness, or difficulty speaking. Cognitive changes. Memory loss, confusion, or other cognitive changes can occur in chronic cases. Seizures. Inflammation or ischemic damage to cerebral vessels can precipitate seizures. Stroke-like episodes. Vasculitis can reduce blood flow to certain regions of the brain, leading to transient ischemic attacks, TIAs, or strokes. Diagnosis. Imaging. MRI with contrast or MRA, magnetic resonance angiography, can help visualize blood vessel abnormalities in areas of inflammation. These might show vessel narrowing or ischemic changes. Cerebrospinal fluid, CSF analysis. Lumbar puncture can reveal elevated protein levels or pleocytosis, which may suggest an inflammatory process. Biopsy. A definitive diagnosis of CNS vasculitis often requires a brain biopsy, though this is rarely performed due to its invasiveness. Blood tests, markers of inflammation such as elevated ESR or CRP, can support a diagnosis, but they are nonspecific. Tests for autoimmune conditions, e.g. ANAA, may also be considered to exclude other causes. Management, smoking cessation, essential in preventing further vascular damage and inflammation. Immunosuppressive therapy. Corticosteroids or other immunosuppressants like cyclophosphamide may be used to control the inflammatory process in CNS vasculitis. Antithrombotic therapy. Anticoagulants or antiplatelet agents might be considered, particularly if there is evidence of a hypercoagulable state or thrombotic risk. Symptomatic management. This can include anticonvulsants for seizures or rehabilitation for neurological deficits. Prognosis. The prognosis of smoking-induced CNS vasculitis depends on early diagnosis and intervention. If left untreated, the condition can lead to progressive neurological impairment or permanent disability. However, with proper management, symptoms can be controlled, though the risk of recurrence may persist if smoking continues. This condition remains a rare entity and should be differentiated from other causes of CNS vasculitis, such as autoimmune vasculitides, e.g. lupus, A-associated vasculitis, and infectious causes. Yes, smoking-induced CNS vasculitis and Cogan syndrome are different conditions, though both involve inflammation of blood vessels and can impact the central nervous system, CNS. Here's a comparison of the two, highlighting their distinct features. Cogan syndrome. Cogan syndrome is a rare autoimmune disease characterized by 1. Inflammation of the eyes. It typically presents with interstitial keratitis, inflammation of the cornea, though other ocular symptoms like uveitis or scleritis can occur. 2. Vestibulo-auditory involvement. This includes symptoms like hearing loss, tinnitus, and vertigo, often resembling Meniere's disease. These symptoms arise from inflammation of the inner ear structures. 3. Systemic vasculitis. Some cases may involve systemic vasculitis, affecting larger vessels and potentially leading to cardiovascular complications. Less commonly, Cogan syndrome can involve the CNS if the vasculitis extends to the brain's blood vessels. Smoking-induced CNS vasculitis. This condition is primarily driven by the toxic effects of smoking on blood vessels and immune dysregulation. Its main characteristics include 1. Direct impact of smoking. It is specifically related to the damage and inflammation triggered by tobacco toxins, which can compromise the integrity of blood vessels within the CNS. 2. Isolated CNS involvement. Unlike Cogan syndrome, which involves the eyes and inner ear as hallmark features, smoking-induced CNS vasculitis primarily targets cerebral blood vessels. Symptoms tend to manifest as headaches, cognitive changes, seizures, or stroke-like episodes. 3. No specific autoimmune features. It lacks the typical autoimmune markers seen in systemic autoimmune conditions like Cogan syndrome. Key differences: etiology. Cogan syndrome, autoimmune mediated with a strong association with eye and ear involvement. Smoking induced CNS vasculitis, directly related to the vascular damage caused by smoking. Systemic involvement. Cogan syndrome often has systemic features like fever, fatigue, and large vessel vasculitis, in addition to ocular and vestibulo-auditory symptoms. Smoking-induced CNS vasculitis primarily affects the CNS without the characteristic systemic or eye-ear symptoms of Cogan syndrome. Diagnosis: Cogan syndrome. Diagnosed based on a combination of ocular, vestibulo-auditory symptoms and evidence of systemic vasculitis. Smoking-induced CNS vasculitis. Diagnosis focuses on a history of smoking, evidence of CNS inflammation, imaging, CSF analysis, and exclusion of other causes of vasculitis. Overlap and misdiagnosis. Though they have distinct features, both conditions can present with neurological symptoms if CNS involvement is present. For instance, Cogan syndrome could potentially be misdiagnosed as smoking-induced CNS vasculitis if its eye and ear symptoms are not prominent. Careful clinical assessment and history are essential for differentiation, as the management strategies would differ significantly between the two conditions. Cogan syndrome may require more aggressive immunosuppressive therapy to manage systemic and autoimmune components. Smoking-induced CNS vasculitis places a strong emphasis on smoking cessation alongside immunosuppressive or symptomatic management for the CNS inflammation. Understanding the specific clinical context and patient history is critical for making the right diagnosis and choosing the appropriate treatment pathway.